Good morning, everyone. Thank you for joining us this morning. We're just waiting for a few more folks to join, and then we will begin shortly. Thank you. Good morning, everyone. Thank you again for holding. We are just waiting for a few more folks to join, and we will get started shortly. Thank you. Good morning, everyone. My apologies. We're having a few technical difficulties that we're just trying to get ironed out, and we'll start shortly. Thank you very much. Good morning, everyone. We will now begin our hearing. Commissioners, in a moment, your audio and video will be turned on. Commissioners, you now have the ability to start your audio and video.
Good morning, everybody.
Good morning.
Apologize for the delay. Has something to do with electricity. Nobody can ever explain it. And I learned that from a movie a long time ago talking about Tesla, not the current one, the other guy. But let's go ahead and launch into this. This is our public hearing on COVID-19 and children's mental health, May 27 of 2021. I understand that Dr. Galley has a hard stop at 11 o'clock, so I'm going to go through my opening remarks somewhat quickly. I'm the chairman of the Little Hoover Commission. Thank you all for joining us today. I want to introduce the other commissioners who are here with us on Zoom. We have our vice chair, Sean Varner, commissioners Dion Aroner, David Byer, Cynthia Buisa, Bill Emerson, Kathy Schwamberger, and Jana Sidley. We also have Assembly Member Quirk, I see, and it's my understanding we may be joined by Senator Jim Nielsen.
Yeah, I'm on.
Senator Nielsen is on, Mr.
Oh,
Chairman.
wonderful. All right, great. Thank you.
I'll be here till 11:30. Then I have to get ready for floor session.
Understood. Thank you for your time. Also with us today are the commission staff, Executive Director Ethan Rarick, Deputy Executive Director Tamar Foster, Project Managers Crystal Beckham and Tristan Stein, and Analyst Sherry McAllister, Ashley Hurley, and Rachel Mattioli. Let's do a little bit of housekeeping. The commissioner's audio and video will be turned on throughout the duration of the hearing. Commissioners, you may mute yourself if you wish. Remember to unmute yourself if you want to make a comment or a question during the hearing. And I would suggest to our witnesses, please don't be offended if you're interrupted by commissioners. All that really means is that we're paying attention and we have questions we want to ask you, and we understand that your time is limited. The video and audio of our hearing witnesses will be turned on as they speak. Members of the public will be muted during the hearing. As is standard for the commission, we'll have a public comment session at the end. Those who wish to make a comment will be unmuted during that time. If you want to make a public comment, please use the raised hand feature in Zoom by clicking on the hand icon and join the public comment queue. Some of you may have joined by phone. Please send an email to littlehoover@lhc.ca.gov indicating you want to address the commission. You must provide the phone number from which you have joined the meeting so our staff knows who to unmute. Staff will be monitoring raised hands and emails requesting comment throughout the duration of the hearing. Public comment is limited to 3 minutes per speaker. We're recording today's hearing, and after the meeting, it will be placed on a permanent link on our website and going up on our YouTube channel. Now, as to the substance of the hearing. This is the last of a series of 3 commission hearings on the COVID-19 pandemic's impact on children's mental and emotional well-being. In the previous hearings, we heard from child mental health experts and advocates, as well as from child mental health providers and stakeholders. They talked to us about their experiences working with and navigating California's child mental health system. They identified systemic and structural barriers that may prevent children from accessing care and services. Today, we'll hear from 3 key state leaders on how state government is responding to COVID's impact on children's mental well-being, and how state agencies are working to strengthen California's system for supporting child mental health. Improving California's mental health system has been a longstanding priority for this commission. Most recently, in 2015 and 2016, the commission issued 2 reports on California's mental health system. Based on the testimony we have heard in the previous hearings on COVID and children's mental health, the commission believes that the findings of these reports remain very relevant. In the earlier hearings, witnesses emphasized that state leadership and clear outcome goals are needed to overcome the fragmentation of California's mental health system and to meet children's mental health needs. These points were central recommendations of our commission's reports in 2015 and 16. Here's what we called for: stronger, more coherent, and more cohesive state leadership over the mental health system. And we urge the governor and the legislature to identify a mental health leader within state government who is able to ensure accountability for outcomes. We also called for identifying statewide goals to evaluate mental health programs and recommended that California establish a statewide mental health data system to track outcomes. You can't manage what you don't measure. 2 weeks ago, Governor Gavin Newsom proposed a major overhaul of child mental health care in California, the Children and Youth Behavioral Health Initiative. This initiative will provide $4 billion in investment to children's mental health and aims to establish a comprehensive system of mental health care for Californians from birth to 25. This proposal has the potential to fundamentally transform California's child mental health system. We anticipate that today's witnesses will speak about the Children and Youth Behavioral Health Initiative, as well as other ongoing efforts to better support children's mental health. As the administration and state agencies take steps to strengthen California's system of mental health, consideration of this commission's earlier reports and implementation of recommendations will go a long way towards increasing the likelihood of success. Now I'd like to ask the project manager for this hearing, Tristan Stein, to please introduce the first witness. Thank you.
Thank you, Mr. Chairman. It is my pleasure to introduce as our first witness this morning, Dr. Mark Ghaly, Secretary of the California Health and Human Services Agency. Dr. Galley was appointed in 2019 by Governor Gavin Newsom as Secretary of the Health and Human Services Agency, overseeing California's largest agency dedicated to healthcare and safety net services. Previously, Dr. Galley was Medical Director of the Southeast Health Center, a public clinic in San Francisco. In addition, in 2011, Dr. Galley became the Deputy Director for Community Health and Integrated Programs for the Los Angeles County Department of Health Services. Dr. Galley earned his MD and his Master's of Public Health from Harvard University. Secretary Galley, please.
Mr. Chairman, I believe it looks like Dr. Galley is muted. Ashley, can we?
Yes, we've asked him to unmute on his end.
Yeah, we understand he's going to participate by phone because there was
correct. Yes, Mr. Chairman, I also did want to mention, and my apologies to the commission, we've had some technical problems getting Dr. Galley on with video, and so he is going to testify by phone only, but I believe that we are still having some technical problems. So
do you think maybe the string and the two cans weren't long enough?
Unfortunately, Mr. Chairman, while we work on this problem, we may need to ask if Dr. Burke Harris is able to testify now, and I apologize to the commission for this technical problem. I understand we're working with Dr. Galley, but unfortunately we have not yet been able to activate his video. There's some problem between his end and our end. So I think that let me ask Tristan if he can actually now introduce Dr. Burke Harris, and we will ask her to testify. We'll take the witnesses out of order and we'll see if Dr. Burke Harris can testify. We'll try to work on Secretary Galley's technical problems and see if we can get him back in before his commitment at 11. And if not, perhaps we'll be able to arrange another meeting for him to testify. Again, apologies to the commission. Tristan, can you please introduce Dr. Burke Harris? And Dr. Burke Harris, we're going to ask you to testify now.
Thank you, Ethan. So our first witness this morning will be Dr. Nadine Burke Harris, Surgeon General of the state of California. Dr. Burke Harris was appointed as California's first ever Surgeon General by Governor Gavin Newsom in January 2019. She is an award-winning physician, researcher, and advocate dedicated to changing the way our society responds to one of the most serious, expensive, and widespread public health crises of our time, childhood trauma. Dr. Burke Harris, please.
Thank you. Thank you so much for that warm introduction and for the opportunity to testify before this commission. And let me go ahead and pull up my notes here. Just one moment.
And Dr. Burke Harris, I apologize for having asked you to testify second and then we put you first. So
no, it's totally fine. I'm happy to do it. I'm so grateful for the opportunity to participate in this hearing on COVID-19's impact on children's mental health. I believe that each of us recognizes that the pandemic has been disruptive, stressful, and for some, frankly, traumatic. It's had a profound effect on our entire society. However, children are uniquely vulnerable to the harmful impacts of stress and trauma because their brains and bodies are just developing. Experiencing high doses of adversity without adequate buffering caregiving can alter children's developmental trajectory and increase the risk for chronic medical and mental health conditions throughout the life course. As California's Surgeon General, I feel it's my duty to issue a stark warning that without intervention, the pandemic will likely have significant and detrimental effects on the health and well-being of our children and youth for decades to come. The science demonstrates that when children are exposed to high doses of adversity without adequate buffering caregiving, the prolonged activation of the biological stress response, known as the toxic stress response, can alter brain architecture, immune functioning, hormonal regulation, and even the way DNA is read and transcribed. Research from the CDC and others documents that individuals with 4 or more adverse childhood experiences are, on average, 4.5 times as likely to develop depression, roughly 7 times as likely to become dependent on alcohol, twice as likely to develop ischemic heart disease, 3 times as likely to develop chronic lung disease, and 11 times as likely to develop Alzheimer's. I want to be clear that not every stressor is damaging. Moderate amounts of stress in the context of supportive caregiving are normal and even healthy for development. However, high doses of adversity without adequate buffering care can lead to the development of the toxic stress response and the resulting harms. The COVID-19 pandemic has been unique in its effect in acting as a major stressor while simultaneously cutting off access to many of the usual sources of buffering care necessary to help children and parents regulate their stress responses, such as grandparents, teachers, coaches, faith leaders, and in some cases, childcare providers. While the pandemic has been hard on all of us, no matter our age, socioeconomic status, or race, low-income communities and communities of color were most impacted, experiencing significantly higher infection and death rates and disproportionate rates of job loss, housing loss, and difficulty meeting basic needs when compared to our most advantaged communities. Our caregivers were asked to do the impossible, continue working while also supporting young children through e-learning. Even for those who were most well-resourced, this was a fairly untenable task. And many caregivers lost jobs or had to quit in order to support their children who no longer had in-person school or childcare options. The short-term impact of these stressors is manifest in what we see in the national data. A study from the Kaiser Family Foundation found that the number of adults reporting depression or anxiety increased from 11% in June of 2019 to 41% in January of 2021. According to the CDC, as of June of 2020, 13% of Americans reported starting or increasing substance use as a way of coping with stress or emotions related to COVID-19. A study from the National Commission of COVID-19 and Criminal Justice found that domestic violence incidents spiked by more than 8% nationwide in 2020 following the implementation of stay-at-home orders that were necessary to stop the spread of the pandemic. We now have an extraordinary number of children and families experiencing significant adversity and an extraordinary number of adults whose own stress response may put their children at risk due to lack of access to sources of buffering. Unless we intervene robustly, the consensus of scientific evidence suggests that we are very likely to see an unprecedented increase in toxic stress. Some of this will likely manifest in the short term through behavioral health, mental health, and learning challenges. Some of it may manifest later in terms of higher incidence of cardiovascular disease, incarceration, cancer, stroke, and other health conditions. We already have a baseline for how that may impact our state economically. Research done prior to the pandemic estimates the annual cost of adverse childhood experiences in California at $112.5 billion. That includes $10.5 billion in personal healthcare spending and $102 billion in years of productive life lost due to early death and disability. But the good news is that there is a path forward. Scientific consensus supports two core principles. One, that early detection and early intervention can prevent and mitigate negative outcomes. And two, evidence-based interventions are healing. And by intervening early, the intervention can be less intensive, less expensive, and is also more likely to be effective. California is already ahead of the game with the launch in January of 2020 with the first ever initiative to train healthcare providers on how to screen for adverse childhood experiences and recognize and respond to toxic stress with evidence-based interventions. The ACEs Aware initiative seeks to lessen the long-term impact of adverse childhood experiences by training and paying Medicaid providers for ACE screening in both children and adults. It is part of a statewide effort to cut ACEs and toxic stress in half in a generation, and to date, more than 17,000 providers have been trained. The time for a sea change in investments in children and youth mental and behavioral health is now. As Secretary Ghaly will note in his comments, the governor's budget and the California comeback proposals present a $4 billion investment in a number of new initiatives that in combination will transform our system for providing behavioral health care services for children and young adults through the age of 25. These investments aim to prioritize our children's mental and behavioral health, not just as we emerge from the pandemic, but well into the future. Investing $4 billion now is a drop in the bucket compared to the cost to the state of toxic stress now and in the future. These recommended transformations align with guidance from the American Academy of Pediatrics, the CDC, the National Academies of Sciences, Engineering, and Medicine, and the recently issued report from my office, Roadmap for Resilience, the California Surgeon General's report on adverse childhood experiences, toxic stress, and health. As further outlined in the Roadmap for Resilience report, a public health approach to tackling toxic stress requires a comprehensive model of prevention, early detection, and evidence-based intervention. None of these is sufficient on its own, and each enhances the efficacy of the others. Dr. Ghaly will outline the key components of the governor's proposal, so I won't go through them in detail, but I do want to highlight and reinforce the importance of a few key elements. Public awareness is essential to enable early intervention so that people don't wait until they're in crisis before they're willing to accept support. Screening to support early detection and intervention is essential for improving outcomes on a population basis. To make a difference, we must deploy cross-sector and equitable response solutions, models, and best practices that can be tailored to serve each community's needs. That includes doubling down on and continuing to build resources for our primary care and behavioral health workforce, but also better preparing resources outside of the traditional confines of the doctor's office, such as school-based resources, so that strapped parents don't have to take time off of work and take their kids out of school for weekly appointments. We also need to train educators about the impact of adverse childhood experiences and toxic stress, how to recognize the signs and symptoms, and how to support students in trauma-informed environments rather than reacting with harsh, punitive approaches. Restorative discipline practices and programs to prevent re-traumatization should be the norm.
Can I interrupt?
Sure.
Sorry. This is Commissioner Beyer. I'm very impressed by your recent report. Thank you for that. And your book and your TED Talk, I'm all in. As a past chair of a FQHC in Oakland, I know your work firsthand and I know how important it is. Let me focus on one gap that you've identified and that the governor correctly identified in his plan, which is the personnel gap. That is the number of psychiatrists, psychologists, and social workers who exist in California today and who will be in place in 5 years is completely inadequate to provide the necessary personal care that children and their parents need. And so the governor's called for a massive training program, particularly focusing on community-based organizations in order to achieve both access and equity. Help me understand how something that big and that complicated is going to be implemented when it requires a combination of the Department of Health and Human Services, as well as the state's, frankly, fragmented training programs, inconsistent community college focus on such things. How's there going to be a comprehensive plan that deals with the scale and urgency that you're talking about to train up the people necessary to offer care to the people who've experienced adverse events?
Certainly. I will allow Dr. Ghaly to speak more deeply into the specifics of the implementation. But what I can say is that there's a lot that we can learn from the way that we have been training our healthcare providers with the ACEs Aware initiative. I think that what we recognize is that there is some training that's based on the raising of standards, the fundamental training that goes across the board. And while there's some deeper dive work that can happen in terms of taking the best practices, and this is one thing that is outlined in the governor's budget, is lifting up of the best practices and disseminating those best practices in training programs that go broadly across our providers. I think when you talk about the implementation and the specifics of how we do that, part of that involves bringing together leaders and experts in the field to be able to support the design and implementation of some of these training programs. But I would really leave it to Dr. Ghaly to speak more specifically about how that implementation is going to take place.
Yeah,
Thank you.
Yeah, thank you. This is Pedro Nava. Dr. Galley is now unmuted. And so what I would suggest, since he made some changes to his schedule, he's going to stay with us till 11:15. And I actually think that what we can do at this point is have both Dr. Galley and Dr. Nadine Burke Harris share this time together, if that makes sense to the witnesses and to the commissioners. And I realize there have been some things that are better address Dr. Galley, as you've indicated. And so why just invite him to attend at this year and the duet.
And
Dr. Galley?
Great. Are you able to hear me now?
Absolutely.
All right. So let me begin by apologies. In my year plus of Zoom, this has been the hardest technical issue that I've faced getting on. So I apologize for anything on my end that happened. Commissioners, really was looking forward to the opportunity to testify here with Dr. Burke Harris and share with you what we think is both a bold plan but a timely plan. And Dr. Burke Harris's testimony, I think, highlights so many of the reasons why we are excited to be part of this conversation. And I will start by saying that it is often said that how we spend our resources, time and energy is a true reflection of our values. And I'm proud to be part of the governor's team that put forward a budget that puts so much emphasis on children's behavioral health. We have talked about in this hearing and so many other opportunities about the impact of the pandemic on young people, the losses that they've endured, the level of resiliency we've depended on. And in one article recently that the resilience of young people is starting to run out. Denver Children's Hospital just yesterday or the day before declaring a mental health crisis for children for their city, for their state, seeing this place by place, state by state, locality by locality. The privilege of talking to the children's hospitals here in California just a couple of days ago, to hear that despite having overall reductions in the number of emergency room visits, for overall, they've seen a 35% increase in the number of young people emerging, coming to their door, looking for help and treatment for behavioral health conditions. We also know that before the pandemic, we were, we had quite a crisis brewing. Both Dr. Burke Harris and I started our clinical careers in the southern part of San Francisco and Bayview Hunters Point, and we worked on these issues decades ago now, worried about what we could do, and it's only accelerated and become more urgent. We are privileged to try to put a proposal together that closes those gaps, that really does attempt to transform California's children and youth behavioral health system into one that is a world-class, innovative, upstream-focused, early intervention-focused ecosystem where we can promise all of our young people that we will be looking out for their emotional, mental health needs, that we will be able to screen them and assess them in a timely way, support them with emerging and existing best practices in a culturally competent and equitable fashion. And the one question that I heard was, well, how do we implement some of these complicated features of this proposal? And I will tell you that it will be not easy. It will take a lot of innovation, a lot of rolling up sleeves. But I think the 7 components that I'm going to lay out quickly as part of our proposal will each need to happen, but they happen in a braided, coordinated way that requires us at Health and Human Services to do our important part, the many departments within Health and Human Services to carry their part, but also many other partners, whether it's the education community, not just the K through 12 and the California Department of Education, very appreciative to our superintendent of public instruction, Mr. Tony Thurman, and his partnership, but also Toby Ewing and so many others. Toby, I know, is going to be joining us as another witness in a moment, but so many others to really roll up our sleeves and come together in a coordinated way to implement each of these components of this important proposal. So it starts with a virtual behavioral health platform that really capitalizes on the lessons learned before the pandemic, but really during the pandemic, on how useful virtual tools can be in delivering health and public health interventions. We saw overnight California's health system basically flip from almost entirely in-person services to very much depending on virtual services, mainly in the form of one-on-one visits, some group visits. But we, over the course of the pandemic, have evolved and created a whole suite of tools to allow people to connect, to have access. Although imperfect, it has been a valuable place to learn and innovate and accelerate our own understanding of how to use this tool. And the proposal that the governor's proposal is one that starts with a large statewide behavioral health platform that allows every young person 0 to 25 to have access to around-the-clock tools, around-the-clock assessments, around-the-clock opportunities to get the support and care that they need. The second component is building up the capacity of some of the key partners. So much of what we do on health runs through our health plans, both Medicaid, managed care plans, but also commercial plans as well. So really building up the capacity, the knowledge of those health plans, county behavioral health plans in particular, that play such a critical role in early interventions today, and especially providing care to those with more significant behavioral health needs. We heard about the community-based organizations, the criticality of their role, not just in being important connectors, but in the future, providing that early intervention and care, some of those assessments, training, as Dr. Burke mentioned, to build up that capacity. And then schools. We talk about this work being school linked. Of course, some of it will be school-based, but not every school is either immediately or into the future going to have the capacity, both physical space or personnel, to be able to have everything be school-based. But the idea that it is school-linked, that we're supporting the staff at schools to be part of that early warning system that we need to do this well and be upstream, is going to be critical. So this will have a significant interaction with schools and creating the infrastructure as part of what we do to make sure schools are equipped to be there for their students around emotional and social well-being. We will develop and ramp up our evidence-based practices and programs in California around children's behavioral health. This is not just on the emotional and mental health side, but also the mostly inadequate substance use disorder side for young people. I often talk about how 2/3 of young people in California with known mental health challenges are not getting the care they need. That number goes up to 90%. So 1 in 10 young people with substance use disorders and substance use challenges are getting the care that they need from the system. So we have a long way to go. We must build it up. We must look at the evidence-based programs, and this is a commitment to do that. We also are expanding certain benefits within Medicaid. We're working with our private commercial partners to make sure some of those are also expanded on the commercial space so that all young people can depend on a suite of services that are going to be available. To your point around training, what we fund, people will train to, where there are jobs and opportunities to provide the care, we will see. So making some important investments on the ongoing Medicaid services is another key feature of this proposal. Those include community health workers, the work that Dr. Burke mentioned around ACEs and screening, and also dyadic services, which really look at the family and child unit together, taking context that matters, trying to stitch together a plan of services that can make a difference in the lives of young people within their certain family or caregiver settings. We heard a little bit about a massive investment in the workforce. Suggestion of nearly $900 million over the course of the next few years to be invested in building up the workforce, not just at the most acute end, not just child psychiatrists or nurse practitioners with a specific focus on children's behavioral health. We need more of those, but also building out the entire continuum of the care delivery model, including peers for older young people, those 18 to 25, but for our youngest clients and patients and kids, making sure that there is a whole host of behavioral health coaches and people who can be immediately available to meet the needs of individuals who we identify through the virtual platform as needing additional services. We also will be focused on these projects in alignment with our community colleges, our UCs, our CSUs, other entities that can help support the training of individuals in a rapid fashion, so that no longer in a handful of years, as we do today, where we say, if only we could refer this young person to the care that they need, but there's no one there to pick up the referral, we can no longer have that as the excuse in California. We need the robust workforce. We will build it, as complicated and challenging as that piece will be. We are committed to working across state government, across local government, with education partners to make sure that that workforce is identified, trained, and looks and speaks the languages of California. As Dr. Burke Harris, and I'll just wrap up with the last two components very quickly. As Dr. Burke Harris mentioned, we will also be there to support primary care providers with immediate assistance as many of these issues flow into primary care practices across California. So a statewide e-consult or e-referral platform, a strong public education campaign that normalizes the need for behavioral health services and gives people an opportunity to understand and frankly continue to work on stigma and reducing the stigma around young people getting behavioral health needs early. And then the last piece, and this is, although small in funding, critical, a key coordination piece. We've heard time and time again the lack of coordination for major efforts. We are committed to coordinating this at agency, at Health and Human Services, but with so many other partners, and making sure that we bring in the right subject matter experts to help each of these pieces that I've outlined get done expediently, but in a high quality way. And then, of course, including a strong evaluation component to ensure that we have the data to support what we've done and be able to pivot and change what hasn't been proven to be working. So that is a quick summary of where we are heading, the proposal. Look forward to answering the questions and sharing this time with Dr. Burke Harris. If there's anything for either one of us, we'd be happy to take those questions now or later.
Thank you. Let me jump in. This is Pedro Nava again. I have three commissioners who've indicated they want to ask questions. Sean Varner, Commissioner Buiza, and Commissioner Byer, at least at this juncture, and also Commissioner Aroner. So let me go to Vice Chair Varner.
Good morning. Can you hear me okay? I have a just a threshold question. I have a threshold question with regard to the. I'm impressed with all the work that's been done to look to solve these issues for our children. I noticed in some of the testimony there's funds that are dedicated to outside resources that will develop and manage some of this process. So my concern is how do we ensure that the funds that are allocated for these programs will be efficiently applied, and who's actually going to be managing and overseeing this to ensure that those funds go to where they should be directed?
Well, I think it's an excellent question, and something that's big. We need to be mindful of that, and I certainly am. I look at the work I've had the privilege of leading at the county level and now at the state level, and accountability and coordination is going to be key. We are going to, at Health and Human Services, really begin and lead this, especially up front. We are going to be bringing in a suite of consultants and experts from across the state, across the nation, who have experience, especially with the virtual platform. That is really a bold step to say we're going to have something statewide, that we don't expect every county to come up with their own version of the virtual platform. I think is going to be both a pivotal but monumental step for us. So we know that we have some of the expertise within our state government and county supports, but we also know that we're going to be bringing in some people who can help us accelerate that. So we are going to take that coordination responsibility on at Health and Human Services. We'll be working closely with departments within Health and Human Services and beyond, and we will be holding ourselves accountable, reporting back, making sure people understand how we're making some of those decisions. We will be creating a rich table of individuals who will help advise and guide some of this, because we know that this can't be done in a silo. For something to be truly all of California, it needs to be broad reaching, and we expect to be able to create that kind of table. And then our evaluation will also not just look at the evaluation of outcomes, but also give us a chance to look at the evaluation of our processes in order that we make sure that we tweak it and pivot it as we go along, because something like this in this topic area has not been done, not just in California, but we're not able to track it being done anywhere in the nation.
Thank you. Does that answer your question, Sean?
Yeah, thank you for that.
Right. Commissioner Buiza?
Good morning. Thank you, Dr. Harris and Dr. Galley for joining us this morning. In my day job, I work with immigrant and refugee populations, especially low-income populations. And so my question really is around language access as a barrier, as well as immigration status as a barrier. Half of California's children at least have one immigrant parent, and one constant feedback that we receive from the community is sometimes how hard it is for especially limited English proficient populations to understand and access some of these services and programs. And given how big the amount of resources that we're looking at from the federal and state stimulus fund and the governor's budget right now, how can we ensure that we really address these enduring barriers that's faced by these communities?
I'll start, and then Dr. Burke, please jump in. First off, 100% have been cognizant of that challenge, and frankly speaking, our healthcare systems have been playing catch up on language access and cultural competency since the beginning of time. And for California, what we've learned during the pandemic is we must lead with equity. We must be considerate of those the different languages, the different cultures, that services must be delivered in to be effective. And I heard just last week on a visit to a university-based early psychosis center how the language barriers create serious inefficiencies in delivering and care. And when timely care is so vital as it is in behavioral health, with behavioral health conditions, losing time because of cultural incompetence, lack of language concordance is really lost time that we shouldn't excuse. So the workforce efforts that we have outlined will be led by an interest in finding individuals who want to do this work, are willing to be trained and choose this as their profession, as their trade, who speak the languages of California, who speak the languages along our border communities, who can make that connection. So in some ways, because we have such this incredible opportunity to recreate the workforce in children's behavioral health, we have a chance to do it the way that elevates those needs of California, unlike in some other areas. And the idea that not only are we going to train the 6 and 8 year degree professionals, but individuals who can use their community knowledge and community professional, if you will, to add a whole skill set around behavioral health and mental health is a unique opportunity to fill those gaps that you mentioned, not 5 years from now, but hopefully in the next couple of years as well.
Thank you. Commissioner Byer and then Commissioner Aroner.
Dr. Ghaly, thank you very much for your leadership and your testimony. I don't have any substantive disagreements with what the governor has proposed. I do have really two different kinds of questions. They're interrelated. One, it's clear that much of the money that the state's going to be able to spend on behavioral health comes from the federal government, and it comes in a series of different packages with different funding deadlines, different parameters, different rules. And that's a challenge for the state to implement. It's possible to spend a lot of money very quickly, let's say on broadband, and that's a good thing, but that's not expanding the people who can offer care. So the one observation I want to leave you with is earlier work done by the Little Hoover Commission has focused on the power of a approach to funding based on the Obama administration race to the top. That is offering, in this case, it would likely be counties, a minimum amount of money, but then encouraging a competition for the best county proposals to fund other things. So I would just urge you to think through and help us and the legislature understand how you're planning on allocating the money and what tools you're going to use to facilitate getting the best possible outcomes with the greatest degree of attention to the fiscal situation. And every previous project the legislature has undertaken or the executive branch has undertaken has been accompanied by a lot of scrutiny. So I would just urge you to think through a year from now or 2 years from now, how to explain problems in funding. And I think that's what Commissioner Varner was getting at. One way of doing that is to have a transparent, competitive process to achieve particular goals. I'll just ask for your response.
Sure, and I think one of the opportunities here, and when we talk about all young people 0 to 25 in California, we mean all. We mean that it won't matter if you're in the northernmost part of the state in Siskiyou or you're in San Diego. We're looking to make sure that we have a virtual platform that isn't different flavors based on your zip code, that it looks similar, that it feels similar, that the same expectation for young people is statewide. So that is a piece. There'll be components of this that we believe will have a real statewideness, although everything we know is going to be connected and implemented locally. And that's where our partners in county mental health, county behavioral health broadly are going to be key, and being able to support their work and their gaps in doing this work so that we create that comprehensive continuum is going to be important. So there'll be a component, obviously, that gets coordinated and worked through with our county partners. And then we know that certain other entities like health plans, some of which are broader than just the county, will be partners to make sure that this gets delivered. This is not a program just for Medicaid beneficiaries. Often the state, and we've had questions that seem to focus on the work for Medicaid individuals, Medicaid beneficiaries, and of course, they're going to be a key priority. A state, we're responsible in so many ways for their care, but working with those commercial plans as well, I think is going to be important. So this can be complex on a number of levels, and I like the idea of really trying to push all of our partners, counties and others, to think through what it is, the sort of race to the top concept or competitive best practices, what can be implemented most thoughtfully and efficiently to be able to track that, and reporting back what we learn all along the way, I think does make a great deal of sense. There will be some of this that I think we don't have every answer for today. And something this big should be able to pivot and be iterative. And we expect to invite so many people to the table to be able to have those conversations. So we start strong, but end stronger, if you will.
Thank you. Aaroner.
Yes. Good morning, Dr. Ghaly and Dr. Harris. Thank you so much for doing this with us. It really gives us an idea kind of on the broad picture of what's going to be happening. I actually have 3 questions for either of you. It doesn't matter to me who answers it. The first one is around the lack of new investment in public health. The governor's budget shows nothing new. And I guess what we're hearing out on the street is that local public health departments have a huge role to play, but have been so underfunded for so many years now. And given what we've all just been going through, how important they are to be a partner in all of this that you're doing. They're the ones who studies their local populations, that kind of thing. They are looking at what future health needs are in their own communities and all of that. So I'm interested in hearing how you think they fit in. And then we also took testimony at the first hearing around EPSDT, right? Early periodic screening. I can't get the initials straight sometime. And I'm just wondering how that funding stream, right? Because California has left so many federal dollars on the table because we haven't used that funding stream correctly and taught enough people how to use it, right? Including schools, that kind of thing. So I'm interested in hearing how that fits in to this initiative. And then lastly, I'm presuming that the $4 billion is coming out of some one-time only fund. Maybe I'm wrong, but I'm presuming that a lot of it is. And so the question always is, how do we continue this? Let's say you do a great job, right? But we're into the blank year where money is running out from this original investment, and then we fall off the cliff again, right? And we have a long history in California of proposing things and then not continuing their funding, and they remain pilot projects for the rest of their natural lives because we can't seem to take something statewide. So I'm interested in hearing, how do you sustain this operation if you can accomplish all of the 7 things that you just talked about, including being able to pivot and all of that as we learn as we go along. But most importantly, then how do we maintain this? This is not going to be the only time that we have such severe mental health needs in kids, right? We've had severe mental health needs for kids since I can remember being involved in the legislature back in the 70s. This hasn't gone away. It hasn't gotten much better, to be honest with you. There's a lot of interesting stuff going on, but we have no statewide best practices and that kind of thing, right? We have them regionally maybe and in some counties. So I'm interested in, how do you sustain this after the fact?
Dr. Burke, maybe I can start, especially on the first one, but I'll try to be quick on all 3, and they're really excellent questions. So the first one on public health, and I'll speak specifically to this proposal. The public education and change campaign, we see local state public health as leaders. I have been part of public health systems and programs at the county level in at least 2 counties, and then worked with all of them throughout the pandemic, and am excited for what the future of public health is and will become. And on this specific issue, we speak broadly about the opportunity for public health departments locally to help not just on public or on community needs assessments and understanding the state of behavioral health in communities. Many public health departments help run certain parts of the clinical delivery system in Los Angeles. The entire substance use disorder system lives in the Department of Public Health. So has a very important role on that front as well. But on the engagement, outreach, and campaign to normalize behavioral health needs and accessing services, the plan is to involve public health, our own department at the state, and locals as well, in helping mobilize and move that campaign forward. As it relates to the public health investments during and after this pandemic, the governor's budget or the May revision proposal recommends $3 million to do a assessment of what we've learned, where the gaps are, and how we can plan 21st, frankly, a 22nd century public health infrastructure for the state. We have seen whether it's on issues of data and the platforms that are needed to collect that data, whether it's on testing and tried and true issues of disease investigation, whether it's on vaccine administration and communications and public engagement broadly. On the issues of equity, I think California has done many things that we should be and should continue to be proud of as it relates to the COVID-19 response, but we have also seen many opportunities and frankly missed opportunities. And to take a moment and look at how the public health system of the future will look like, to build plans collaboratively between the state and locals, to consider regional approaches, not just county as opposed to a state level intervention, to really look at different ways that public health can support behavioral health, mental health, substance use disorders, issues of climate, issues of chronic disease. For too long, public health has been separate from the tried and true healthcare delivery system within four walls of clinics and hospitals? How do we bridge that divide so we're doing things together? Where do, in the big plan around CalAIM, which the Department of Healthcare Services is moving out, what is the role of public health departments, not just in communicating some of those services, but helping do the population health work? I think we are in this rare moment where the urgency to figure out what public health needs and how we get it there is also blended with the opportunity to dream differently and imagine a public health approach and system that meets California's needs, not just of this year, but into the future. And I'm looking forward to starting those conversations. In fact, they are starting now so that we can engage with the local partners on those issues. To move to your question on EPSDT, I think the current behavioral health proposal, this $4 billion proposal, is going to open up opportunities to bring down some of those additional federal supports that some people have done a brilliant job bringing into the state. Others have not done as much, and there are opportunities there, and we continue to work with experts. Alex Briscoe comes to mind, somebody I've talked to plenty about this as an opportunity, working with DHCS and so many others to make sure that entitlement, really that benefit for young people, can be seen as an asset and something that we are committed to through this behavioral health proposal. So a lot of not just learning and teaching others how to use it, but also pushing the envelope that we make sure we get the most out of that additional funding source, as well as a commitment to the early. And I always pick up the early and prevention there in that acronym, that here's our opportunity to do that better, differently, and with from a new vantage point in California. As far as the $4 billion one-time investment, let me just say a couple of things that I failed to say in my initial remarks. The $4 billion is $2.3 billion of one-time investments in things like the virtual platform, in things like the workforce investments. Another area that I didn't mention was in brick and mortar facilities. We know that a virtual platform isn't going to take care of every young person's needs. We're still going to have young people who experience that severe first episode or second episode of psychosis and are going to need urgent care centers that are uniquely built for young people, that are going to need inpatient beds on occasion. And we don't have those in California at the scale that we need. Can't tell you how many young people I participated in the direct transfer, either out of county from Los Angeles and a few out of state, to make sure that they got the care they needed timely, because it wasn't available in the backyard of the families with the young people with needs. And we need to make those investments. So 2.3 billion one-time investments, and then 300 million that does not include the federal dollars that we will match to that. So probably north of $400 million each year is going to be continued to be invested in the additional services. And this does not include the important dollars that we can coordinate with and work with on the commercial side to make sure that these services are not just evolving appropriately, do not become just another pilot in California for 3 to 5 years, but are ongoing, and that we can continue to learn from those benefits. So a big chunk of the money is certainly one time for the infrastructure investments. Grateful to be able to put those forward, but we have an eye on sustainability through both state funds that are ongoing, but also collaboration and coordination with existing efforts on the commercial side to bring it all together for all kids 0 to 25 in California.
Thank you, Dr. Galley. We appreciate you rearranging your schedule to give us that additional time. But I think I need to ensure that you get to your next place. So on behalf of the commission, let me express our gratitude for your service, and actually how encouraging it is to hear you speak about the direction you're taking and how you're going to get there. And now we can talk a little bit more with Dr. Nadine Burke Harris. Thank you, Dr.
Let me just say, again, apologize for the technical challenge at the beginning. Grateful for the work that you're doing and taking this on. And Dr. Burke Harris, thank you for your pivot and going before me and really doing an excellent job giving us the context and the real urgency and the need that we all feel. And I look forward to working with all of you on the commission, a number of others who I know are listening in, to make this such an important effort for California that we can be proud of for all our young people. So thank you again.
So Dr. Burke Harris, if you wish.
Yes, yes, I can go ahead and finish my remarks if you'd like. And I was very close to the end there, but you know, although this hearing today is really focused on mental health for children and youth, I really just want to emphasize that mental health is health, right? These investments are also a down payment on preventing incarceration, lost productivity, but also cardiovascular disease, chronic lung disease, cancer, because the mind and body are not separate. And we now understand that addressing the impact of childhood adversity is crucial for ensuring a trajectory of lifelong health. So this pandemic has given us an unprecedented opportunity to take what we know about early adversity and toxic stress and apply it to improving the health and well-being of a generation. We have a roadmap to guide us as we build back healthier, and it's time to put it into practice. So I'm grateful for this opportunity and look forward to taking any more questions that you may have.
Let me open it up to the other, any other commissioners have questions or comments. I just want to, I think what's interesting about this opportunity is I think almost every one of us have known someone who has suffered from issues regarding mental health and the stigma associated with acknowledging that, and that represents such a barrier, I think, for people to get treatment. And what I'm encouraged by is a conversation about these issues of mental health as though it were no different than any other kind of health concern. So that the more that we talk about this and the more that we have another generation of people who are being taught that it's nothing to be ashamed of or afraid of, or to try to disguise or hide, the greater the likelihood that we will be healthier in all manner of what we need to be healthy. And I see Commissioner Byer is unmuted.
Thank you, Mr. Chairman. My question is going to seem a little bit out of left field, but the commission has been holding a series of hearings on police training. And one of the things that we've heard and looked at is the frequency with which police officers are asked to do tasks that are things beyond their purview, their training. And one of them is intervene in situations where a person's in mental health distress. And there are a number of programs, I understand, across the country where instead of calling 911 and having a squad car show up for somebody who's having a psychotic break, there's a social worker or a trained mental health professional who shows up and offers first assessment, diagnostic, and then as appropriate intervention. Is it too much to ask that as we think about this police question to call on your office for suggestions about how we could improve the post process of training police officers across the state to recognize mental health problems and refer people when they confront them, but also to work with local jurisdictions, which is the law enforcement jurisdiction of moment, to make sure that mental health professionals are called out to schools or other places when it's really not a law enforcement matter. So that's really a request.
Oh, I think it's a very important point. I think that how we respond to mental health, where there's not a specific threat to an individual or safety, right? Non-safety related mental health crises, I think, is very, very important. You're absolutely right. There are some models of best practices across the nation that do provide an alternative response other than police presence. And we've also seen models where law enforcement has an opportunity to be a part of the solution. And I think that it's incredibly important, it's incredibly timely, and my office would be happy to participate and lend any expertise in that process.
Thank you.
Thank you. So any other questions, comments from commissioners before we thank Dr. Burke Harris for her testimony? Going once, going twice, sold. All right. Dr. Burke Harris, thank you again on behalf of the commission for the work that you're doing and for the time that you've afforded us today.
Oh, thank you. It's been my pleasure.
Thank you. Tristan, I think you're up again.
Thank you, Mr. Chairman. Our final witness today is Dr. Toby Ewing, Executive Director of the Mental Health, Executive Director of the Mental Health Services Oversight and Accountability Commission. Dr. Ewing has served as Executive Director of the Oversight and Accountability Commission for more than 5 years, following roles in governance reform at the California State Senate, California Forward, and at the Little Hoover Commission. He also previously served as director of the California Research Bureau and the California Cost Control Commission. Dr. Ewing did his undergraduate studies at Grinnell College, received a Ph.D. in sociology from Syracuse University, and served as a Fulbright scholar in Central America. Dr. Ewing, please.
Thank you very much. And I have a couple of slides, if you could put those up. First, I just want to thank you for the opportunity to join you today and to talk about some of the work that we are doing at the Mental Health Commission. And I'm going to do my best to differentiate between the Little Hoover Commission and the Mental Health Commission, through some of this conversation, because there are some areas where we're working in parallel. I was able to submit written testimony. I apologize it came late. As you can understand, there's many urgent priorities happening all at once with the budget, with bills, and the important work that you're doing, as well as the work that we are doing. First, I want to give you an overview of what is on our portfolio, who we are, what we do, how we do it, and talk a little bit about the different components of our work. I will comment briefly on COVID impacts, behavioral health impacts of COVID, primarily because throughout the duration of your hearings, you've had substantial conversation about what that looks like. And then I want to talk a little bit about the ways in which the commission has really engaged in terms of the COVID-specific responses. So Tristan, if you can go to the next slide. Generally, we think about our work is in 4 areas: policy projects, transparency, research and evaluation efforts. And then, this 4th issue is really important. This is how we try to really bring about transformational change in terms of technical assistance and capacity building. So it's through incentive grants and innovation supports. So your next slide, please, Tristan. Thank you. So like the Little Hoover Commission, we do policy projects that are very similar in that we're really trying to understand what's working, what's not working, and how we might improve outcomes. And so these are covers of some of our recent work: fiscal reversion. In some of your prior work, you have raised issues and concerns, as have we, around unspent funds. How do we make sure we're making best use of available revenues? The comment that was just asked about how we respond to how public safety or law enforcement responds to people with mental health needs. We spent 1.5 years looking at this issue, traveling around the country, working with international experts, and now we're really working to implement recommendations from that report. Suicide prevention, we spent several years working with the legislature and the administration. Ultimately, it ended up with the governor and legislature giving the commission authority to write the state suicide prevention plan as we work to draw greater attention to this issue. Now we're working to implement that plan. If you could go to the next slide, Tristan. We've also done work on school mental health, as was referenced in the analysis that your staff provided in support of today's hearing. We currently have a project on prevention and early intervention, which has been a highlight of many of the questions and comments that you've had over the course of the past few meetings, and workplace mental health. And I'll share with you that when we started this work on workplace mental health, there were a lot of questions about why we would focus on the workplace. And with COVID, I think it is much easier for people to understand how the workplace, is a venue for supporting well-being. And it's a pathway for supporting opportunities for early intervention, for services, including crisis services, particularly for the children of employees. And so our workplace mental health project is actually quite exciting. And those two projects, we hope to have some draft materials available for public release in the coming 3 or 4 months. So really important work. And I'll talk a little bit more about implementing those policy projects in a few minutes. If you could go to the next slide. One of the issues that the Little Hoover Commission has raised in the past, and as have we, is who's holding counties accountable? How do we understand what's actually happening? What information is available to understand the outcomes, the impacts that we're having on in terms of mental health and well-being for California? This commission really works around a three-faceted approach to making publicly available high-quality information for Californians to both understand our mental health system and to participate actively in its design and decisions around programs. So we highlight financing or money, programming, and outcomes. And the argument we make is that under the law, under the Mental Health Services Act, our local partners are required to have a robust community planning process. And if you've ever attended a government meeting, it can be very difficult to track what's happening in that meeting. It can be very difficult to do your homework. And so we talked to consumers and family members and other stakeholders and we said, what do you want to know? And they said, well, first we want to know how much money is there? Where is it coming from? What's being used? What money is available for new programming? Which programs are being funded that may not be working as effectively as we'd like them to work? So we set out to actually create very publicly accessible tools that capture information on financing, information on programming, and the most difficult is information on outcomes, as many of you have talked about today. And so I'm going to show you, Tristan, if you could go to the website, the Fiscal Transparency tool. There's been a lot of attention around unspent funds. You can scroll down a little bit. So this is a beta version of an updated Fiscal Transparency tool where we are tracking over multiple years by counties, by MHSA components, revenues, expenditures, and closing balances. And the closing balances is really important because the law envisions that there be a planning process that looks at the available revenues that are in the bank today, plus revenues that are anticipated to come in over the course of a 1-year or 3-year planning timeframe. A lot of detail here. It's in beta. There's some omissions. We do not currently have information on prudent reserves, which is the rainy day fund that counties retain. We also only have data up till 2018, 2019, even though there are some rules that require county reports to be in as of 6 months following the close of the fiscal year. It takes much longer than that. And so we regret that we do not have data from the 1920 fiscal year. And we certainly won't have data for the fiscal year we're about to close, probably until 6 months or 12 months from now, which means it's not as relevant to the planning process, but it does allow us to really present trend information. And as you can see here in the trend, the closing balances have actually been increasing over time. We do anticipate that you begin to see a shift where expenditures outpaced revenues in 18-19. We anticipate for the 19-20 fiscal year and the current fiscal year that's likely the case as well because of the impact that COVID has had both on the economy and on needs. Thank you, Tristan. I'm happy to answer any questions about this, and your staff has access to this. It's still under construction. It's in a beta version, but we want people to use it and give us feedback on it. If you could go back to the slides and go to slide 6. So in addition to the Fiscal Transparency tool, we have data dashboards on our website on criminal justice involvement, numbers of people served, people in full service partnerships, racial and ethnic background, on people being served, our program search tool that allows you to look at somewhere in the range of 2,500 MHSA programs. Part of the challenge we have is the Mental Health Services Act is funding about 1/4 of our public mental health programs. And the information we have is almost exclusively from the MHSA. We've been working to get data on other funding streams and to develop systems to reflect both the broader public mental health system and the broader mental health system that includes the commercial side. The argument we're making is that we need to be thinking, as Secretary Ghaly pointed out, from the perspective of our entire population, rather than through the lens of how we pay for services. The displays that you see in front of you are all current. If you could go to the next slide, please. We have some additional dashboards that are also under construction. So we're tracking suicide incidents and rates as part of our work on suicide prevention. I'm helping to understand. Go ahead.
I'm sorry, I apologize. But as I said when we started this, you will find with this, we will interrupt you. And I can go back to the presentation. So anyway.
I'm sorry, I couldn't hear you there, Mr. Chairman.
Mr. Chairman, your audio is very choppy.
All right, I just shut off my video. Maybe does that help?
Yes.
All right. So Commissioner, a question, and I apologize, Mr. Ewing, but what happens when commissioners, you start a question or a response based on what you said. So Commissioner Byer.
Sure. Well, thank you for your work and your testimony. I guess this isn't anything about you and the work that you do personally, but I ended up being disappointed by the data gaps that you quite openly comment on. One, the gap between the fiscal year information you have, in some cases it's 2016 or 2017, and we're in 2021. And then the incompleteness of the access that you have to be able to integrate different funding forms. What's the solution to the oversight problem you're describing? Because it seems like incomplete information and out of time information isn't going to help policymakers. How do we solve that?
Great question. And I'll tell you, and as Tristan pointed out, I've been working on these data issues for a long, long time. The fundamental challenge here is that our data systems actually were not designed to do what you're looking for or what we are looking for. So what we have to do is use the data we have. And even in the instance where the law says very clearly that for MHSA expenditures, those reports are supposed to be due to the state within 6 months of the close of the fiscal year, we often miss that date. And there's all kinds of reasons for that. But the system was actually set up usually to pay bills. And so we're trying to adapt that system to report out on outcomes. So it can take us, I'll give you some examples. It can take us 2 years to negotiate a data use agreement with another state agency. That 2-year negotiation might allow us to have access to data for 1 year or 18 months. Then we have to do it again. And under those rules, because of how this is often set up, we may have to actually return the data they gave us in the original request.
Can I just interrupt to say that's crazy? That doesn't make any sense.
I completely agree with you. Completely agree with you. And but it's because these systems, again, we did not start with what do you need to know? We typically start with how do we pay? And so there's an administrative data transmission associated with payment. And we have to take that information and extract out of it something that is useful. I'll give you a very compelling case. Under the Mental Health Services Act, counties are required to spend the majority, the word is the majority, of what's called community services and supports funding. It's the largest category, 80% of MHSA funds. A majority of those are supposed to go to full service partnerships. Full service partnerships are for people who are at high risk of homelessness, incarceration, and hospitalization. It's the folks that, very severely ill that mostly captures the attention of people because they're on the streets, they're in jail. That majority at 50% is about $950 million a year, plus any Medi-Cal drawdown that we get. So we're looking at $1 billion annual investment. We can track, based on reporting standards, the reasons that someone has left a full service partnership. I characterize this as we're paying Harvard rates, and we want to know who graduates. And the data shows about 40% of people they exit these programs without meeting goals. And goals are self-defined. And so they're not necessarily the goals that you would have about self-reliance or housing or family connections or whatever we might have as a goal for someone. But when the data comes in, it's not actually tied to a program. It's simply tied to the individual. So imagine if we were tracking high school graduation rates, but we didn't know which high schools those data were tied to. It's because the funding says we pay you for the person. It's not tied to the program. So it's very challenging. It means getting past that means setting clear, articulate goals. We're sponsoring legislation to do this. We have sponsored legislation on this issue several times. It means
what's the impediment to enactment?
Well, there's a funding, but I would say even more than that, it's recognition of how significant it is to have those goals. And this has been your discussion for years. This is a discussion that we had when I was staffing the Little Hoover Commission. This has been work that at the California Research Bureau, the Cost Control Commission, has including in the legislature. And then we need to redesign systems in order to generate the data that you're looking for. And we are actually working to do that. And some of the comments in my written testimony and some of the slides, we have a project on attacking our early psychosis strategies. And if you had Tom Insel present, he has shared that in the United States, the average duration of untreated psychosis is about 18 months, but it's 2 weeks in the UK. We are actually working with 14 counties and UC Davis, UCSF, UCLA, and Stanford to design a system where we can actually begin to monitor the duration of untreated psychosis, deliver an evidence-based practice, and begin to develop the systems for strategically investing in capacity building so we can improve outcomes, reduce wait times, and over time, actually reduce costs. But it's a very big lift. It means significant culture change in what we in the public sector do.
Thank you.
So Tristan, I think we were, so I was going to share with you that, in fact, part of the challenge is getting access to the data is difficult. The data that we often need is not being reported. And the primary issue is the data systems weren't designed that way. If you could go to the next slide. As part of this work, we do research and evaluation, but I wanted to, and that gets at, understanding those data pieces, understanding how programs are influencing outcomes, documenting the kinds of the economics or the impact that we're having. We're a very small, we're larger than the Little Hoover Commission, but we're a very small shop relative to all of state government and our partners in other areas of health and human services. We have several initiatives. And so here's three early psychosis learning collaboratives that I mentioned. We are using small pots of money to create incentives or leveraging county innovation funds to identify evidence-based practices or best practices when that's the best that's available, and working with county partners, community partners, stakeholders, families, consumers to really design learning collaboratives so that we can really strengthen the way our community partners are responding. So in early psychosis, working with an evidence-based practice called coordinated specialty care. We've got about a $14 million investment leveraging federal, state, local, and philanthropic dollars. Alcove Youth Drop-In Centers is bringing an evidence-based practice out of Australia that was adapted to Ireland, South Korea, and Canada. The first youth drop-in center will open next month, and we're hoping that we can really adapt this model The model has been developed in a single payer environment throughout the world, trying to adapt that to the realities of how we fund mental health services. We've made significant investments in school mental health. We're working with 30 counties to strengthen their suicide prevention efforts. We've got initiatives to work with counties and communities on racial, ethnic, and LGBTQ disparities. And we have several projects that are designed to reduce criminal justice involvement, including bringing the Crisis Now model statewide in California using psychiatric advance directives, helping counties link their own mental health and criminal justice data. The comment about mobile response and sending clinicians or peers or therapists rather than law enforcement. The good news is we know a lot about how to do this work. We know a lot about how to serve people. The system is not designed to allow those exemplars to actually grow and thrive across the state. We tend to really focus on the margin of change in our mental health system. We've got a little bit of extra money. How do we spend it? And we tend not to look at the core system that underlies the outcomes that we're achieving and help us rethink this. I was having a conversation with one of my commissioners and said, when we think about remodeling a kitchen or a new kitchen, we don't build on a second kitchen, we upgrade the first one. We need to spend more time upgrading our core system rather than thinking about spending a margin of additional dollars on a small addition. So there's a lot of work to do. I think the governor's proposal is very ambitious. It highlights lots of issues that are key here. My written testimony talks a little bit about some of the COVID impacts that you have already heard about. I will share with you a few things that we have done consistent with our work around COVID. First, we joined the table with the administration, particularly on drafting the FEMA application for behavioral health response to COVID. And we're very thankful that FEMA was able to give California the largest grant in terms of behavioral health response. That allowed us to actually support school mental health, which was highly unusual for FEMA, but they were very responsive. We built a digital platform, very small relative to what the governor has proposed, that was designed to actually create pathways to web and app-based tools to reduce pressure. Ultimately, we said, how do we take pressure off of emergency rooms, certainly mental health pressure, by strengthening hotlines, before that, strengthening warm lines, and before that, giving people access to validated web-based resources. All of this was about we might call it a sequential intercept model to reduce pressure on the most urgent ER space as we were dealing with COVID. We've also set aside $4 million in just budget flexibility in our budget to support suicide prevention efforts, to support more community engagement, to address disparities specifically. We're trying to ramp up our school mental health strategy. I think my closing comments are, we certainly have incredible leaders in California working on mental health. There's a lot of effort that goes into individual initiatives, but we don't yet have a public mental health system. And you heard this earlier in some of the presentations. What we have is a mosaic of 1,500 to 5,000 programs that are all very different. And we know, and we've known for a long time since the work that you did in 2000, that the responsiveness of that system to our needs is really driven by rationing access to care, eligibility standards, and the individual's ability to navigate something that is very complex. I was up late last night helping a father with a daughter who is struggling with some pretty urgent mental health needs. And in other places, we would have dispatched a mobile response to that family and gotten them care within a matter of minutes rather than a matter of months. And even with my help, it may be a matter of months before we can support that family the way we need to. Thank you for the work you do. I'm happy to tell you more about our many initiatives. Really want to save time for discussion with you and responses to your questions.
Thank you, Mr. Ewing. And I see that Commissioner Aaron is unmuted.
Yeah, thanks, Toby, for this, for your information. Really, it's very helpful. I have a question though, because you mentioned that you got the largest grant from FEMA regarding schools and kids on, and I guess what I'm trying to figure out is schools haven't been in session. What's the money going for, right? You know, the kids are elsewhere, to say the least. They're either at home or they're in childcare facilities where they're doing distance learning with people that don't even, you know, that's not what they're supposed to be doing. And so who got this money and where did it go to?
It's a great question. So the way we thought about that was there are really three opportunities to support the needs of children who are in schools. There's the moment we're in right now. And again, this conversation with FEMA, you know, started 12 months ago and the funding was made available 6 months ago. So it really was, how do we support teachers? How do we support administrators, and how do we help them support students that they are seeing and those students that they will see, when that happens? The second phase is the summer. What can we do over the summer months to support children as they return to school? And the third phase is when they return to school. So the funding that we were able to get, it was $6.8 million out of about a $70 million overall COVID grant from FEMA, is really to support the training and awareness, because to your point is we were not providing clinical care, right? But they will be there come the fall. And so we wanted to make sure, because as Dr. Nadine Burke Harris talked about, the literature is very clear. The trajectory of behavioral health crisis of a normal disaster is 3 to 5 years, based on Deepwater Horizon, Katrina, 9/11, right? There is this acute phase, but we can't forget that when we're out of the pandemic, people are vaccinated, kids are returned, they're not well. I mean, they're not like done, right? We don't just say, whew, it's crisis over. There's this long trajectory. So that particular investment is really to recognize that we have to think about this crisis over a 3 to 5 year trajectory. Doesn't mean we ignore the immediate. It means do both. This is a yes and scenario. I hope that answers your question.
It does. Thank you.
I see Vice Chair Varner.
I guess it's still good morning, Dr. Ewing. Appreciate all the work you're doing. And as you know, from back in 2016, when we did our report on the Mental Health Act and the Prop 63, that it's a daunting task. But I was very concerned by what you said to us earlier about the communication and access to information. And this is precisely some of the things that we made recommendations on in our 2016 report. And so I guess my question is, I don't even know if it's a question, but has progress been made from there? Or have some of those recommendations been implemented? Because as I read your testimony and heard some of the challenges you're having, it appears not much has happened since then. And back then we were very concerned about not having access to information from counties. And in fact, we had testimony back then. One person said it would take 5 years just to develop a software system that would allow accurate reporting, which was insanity to me. So have we made any progress? I mean, I know this is off the topic a little bit of what we're discussing today, but I'm thinking maybe we need to revisit our 2016 study and determine what has been accomplished since then.
Well, that's a dissertation level question, right? Are we making progress? I would say absolutely. I think Commissioner Aaroner, Commissioner Emerson, Commissioner Nava, understand that the kinds of questions that the legislature is asking today are very different from the kinds of questions that were asked 5 years ago, 10 years ago, or 20 years ago when I was working for you all, in terms of things like access to data and outcomes. So, I think from this sort of broad cultural perspective, there's tremendous interest and inquiry around data and analytics in ways that, were not true, in 2002. So we've made a lot of progress. You can see that when this commission first revealed publicly the MHSA expenditure data, there was $350 million of MHSA funds that had been sitting in county bank accounts that had not been touched, in some cases for 12 years. And so, we're not seeing those kinds of challenges anymore. We're still seeing very significant challenges. Some counties say we want, and there's reasons why counties don't spend these dollars, right? These are not, bad people making bad decisions. There are structural, cultural, political reasons that incentivize this. Some counties will say, we want to keep 6 months of cash on hand for cash flow needs, right? Nobody wants to spend their entire April paycheck by the end of April. You're going to spend it, in the months that come after that, or the same thing with your annual paycheck. And if we think about it that way, it's probably pretty reasonable to say counties should have about 6 months of cash flow on hand. Part of the challenge is we have a prudent reserve as well that counties cannot access. Counties also often face significant fiscal risk associated with what are 5 to 7 year audit timelines where they have to repay. I don't know another space where the bill doesn't come, where you don't settle up for 5 years, right? We don't settle up with counties in some cases over 5 years. And so there's tremendous fiscal pressure for them to keep cash on hand. But those rates are coming down. And it's because we're having this conversation in ways that we haven't had it before. And we're actually trying to have the conversation not from the lens of how do we punish you, but how do we actually structure the system so that we can reduce those risks, highlight the opportunities for counties to use those dollars more effectively. The other piece of that, and this is really important, and you're seeing it in the governor's proposal around evidence-based practices, part of the reason why we don't have a mental health system from a statewide perspective is the state is not in the business of helping counties build out their systems. We provide funding, but rarely do we say, hey, how do we help you figure out how to reduce justice involvement or strengthen your crisis response programs? We will give out grants and allow counties to sort of, do it their way, which is how realignment was designed. What we have been doing is instead saying, what are the big challenges you're facing? And by showing counties what each other is doing, they're starting to say, hey, you're doing that too. How can we work together to learn together? And the state needs to maintain skin in the game in that. In other words, we need to be equally responsible for success with the counties because they cannot do it alone. We need to support their ability to figure out how to do sustainable financing, which is one of the questions that I think Commissioner Aroner had asked the Secretary about what's going to happen when those short-term dollars are gone. We need to help them with the math about how early intervention investments can reduce long-term costs. LA, maybe San Diego and a couple other counties may have the staff to do that kind of analytic work, but Trinity and Colusa, Glenn, they don't. So we are trying to step into that space. Senator Nielsen is here. Hello, Senator Nielsen. We are trying to step into that space and say, how can we build out the capacity building? Because counties are working too hard to be successful the way you and my commission and Californians, in order to get what we are looking for in terms of the outcomes to be achieved. We have to do a better job helping them be successful.
Thank you. And just real quickly, and this isn't a question, but something probably for staff. I think it'd be interesting for them to follow, or probably critical for them to follow up with you. I'd like to know why it's been taking 2 years to negotiate agreement with an agency for a 1-year agreement. I think that shows a huge inefficiency that we should follow up with you offline about.
I just wanted to say this is why legislating through initiatives is not a good idea, everybody. This was not done by the legislature, this initiative, right? It was done by 2 or 3 people and with no other eyes on it. And then the voters voted for it. And Toby's been living with this for years, right? The limitations. I mean, he mentioned the fact that we are not taking, we're not funding the base where the Mental Health Services Act doesn't fund the base of mental health services in counties, right? And they're dying on the vine there because of the way realignments was set up originally, right? Well, actually how it's even playing out more now, because guess what? When IHSS grows, then mental health declines. The funding of mental health declines in the design of realignment. And so, but doing, while I can't remember what initiative I've ever voted for, to be honest with you. Having been a former legislator, I just don't believe in them. But you get what you pay for, everybody. And not having enough eyes on a proposal. It's the beauty of our commission is we're another set of eyes, but we weren't involved in the drawing up of the initiative itself. And it's flawed. It's just significantly flawed.
Senator Nielsen, I see you. Did you wish to make a comment or ask a question?
If I may, Mr. Chairman.
Of course.
Mr. Ewing, I've been on here the whole time, and I find myself both hopeful and frustrated. And the frustration is a product of the budget. I'm vice chairman of the Senate Budget Committee. I've been vice chairman of the Budget Committee for seems like almost ever. But I'm hearing a lot of things, and I'm seeing tremendous changes now with realignment and impact of realignment on local government and local communities. Not all good. And you've pointed out some of the aspects of it. I'd like to see if it's possible for me to just have a one-on-one with you or you and some of the staff just as soon as possible. To help me get my arms around where we can go as the budget now progresses. Understanding there's not really a budget process anymore. It's just kind of a wallow or a scrum. It's pretty hard to get your hands on, even if you're sitting on the budget committee, how to make things happen. And the disconnect with local government has always been there, but it's even more so now because the relationship of the state and the local governments have dramatically changed, particularly in the area of criminal justice. You've made some points here, but I'm trying to get my handle on how do we substantively get something accomplished in the budget, statutorily in the budget, to give us some continuity and some guidance to the future. And particularly the linkage between the state and local government. More of realignment has just been the Pontius Pilate, dump it on the counties and here it's your problem, it's not ours anymore. I'd really like to do that. Is that a possibility that we could do a Zoom or something like that with you? And
I will reach out to your staff, absolutely.
All right, if you would do that, please. I'm kind of desperate about it. We're kind of wallowing into the end of the budget process or whatever. It's not a process. I hate to say that, but it isn't. But to be able to accomplish something, my frustration is not the people getting our hands around it, and then the sustaining aspect of it. This big money availability, this is temporary, very temporary. How do we sustain whatever we create here with the governor's new bold initiative? Can we sustain any of that in the future? So I'd welcome a conversation with you, sir.
Absolutely. And I'll share with you, I mentioned very briefly our work on mental health in the workplace. We started that project for a handful of reasons. One, we knew that if we could gain support from the employer community, it can be a profound strategy to address stigma. Tremendous capacity in the private sector to really frame out issues and opportunities, just like we see, companies supporting the Olympics, right? And, cancer research and cancer reduction. How do we actually gain employers as partners in terms of stigma reduction? Second, we really recognize that like students, if we want to deal with children, we have to go to the schools because that's where children are. If we're going to work with adults, particularly through a prevention and early intervention lens, we want to make sure that employment as both a place of stress, but also a place that can support resiliency is a partner in this field. The third reason is we often talk about mental health in terms of the public mental health system. We don't do that when we talk about vaccines. We don't talk about vaccinating people on Medi-Cal. We talk about all Californians. And so we really need to think much more expansively about what that opportunity is. And I'll tell you, I've met with the healthcare leadership in some of the largest corporations in California, and every single one has told me, no matter how much money they have, they struggle to get deep-end mental health care for their beneficiaries. They struggle so mightily that, the message is drop your insurance and enroll in Medi-Cal. Mental health is the only space where you're actively encouraged to go down to the county clinic. You don't do that for diabetes, for heart disease, for a brain tumor. For mental health, you do. If we're going to take financial pressure off of our public system, we need to embrace a much more expansive understanding of how we can access care. We've had conversations with CalPERS as one of the largest purchasers and thus negotiators of benefit packages with commercial insurance. So this is really about embracing all of the tools that California has available to address some of the challenges. And as part of that strategy, making it easier to have these conversations around outcomes and monitoring and measures, because those partners understand that work much better than many of us in the public sector. But Senator Nielsen, I'm happy we will reach out to your staff today and get something on your calendar.
Thank you very much. I would appreciate that that assistance as we progress with the budget then. Thank you.
Yep, thank you, Senator Nielsen. Let me ask the commissioners, anybody else wish to either make a comment or ask a question of Mr. Ewing? Well, Mr. Ewing, you have done the impossible. You've satisfied every commissioner. There's no more questions for you. So let me express again, thank you so very much for the work that you're doing. It's interesting to have, a former a member of the Little Hoover Commission staff as one of our witnesses, full circle. That's really good to see. And it's going to be very, very helpful for staff and commissioners as we are able to formulate our recommendations going forward. Again, thank you, sir.
Thank you for the opportunity. Happy to follow up with any questions that commissioners or staff may have. Nice to see all of you. Appreciate it.
All right. So I think that concludes our the testimony from the witnesses for this hearing. Let's take a look to see whether or not we have any public comment.
Thank you, Mr. Chairman. We will move into public comment. I'll ask the staff to put up the instructions for public comment. Those are on the screen now. If you have phoned into the meeting, email us at littlehoover@lhc.ca.gov. Please do that immediately. We're checking those emails in real time. Put your name and the phone number from which you have called so that we know who to unmute. littlehoover@lhc.ca.gov. Or you may, if you have zoomed into the meeting, you may simply use the raised hand function in Zoom. When you are called upon to make public comment, commissioners will be able to hear you, but will not be able to see you. Your video will not be turned on. And per the commission's usual practice, public comment is limited to 3 minutes per commenter. So please keep any comments to 3 minutes. I know that as of a few minutes ago, we did not have any emails. I believe we do now have some raised hands for people asking to make public comment. So I will ask staff to call on those folks for public comment. Again, if you do wish to email us, if you have phoned in, do so now so that we have you in the queue. Ashley, if you can call upon the people who have raised hands to make public comment.
Yes, we're first going to start with Rachel Ronkowski. Rachel, I'm turning on your ability to talk.
Thank you so much. My name is Rachel Ronkowski with Child Care Resource Center. We're a nonprofit that represents families, children, and childcare providers in the Antelope, San Fernando, and Santa Clarita Valleys, as well as San Bernardino County. And in addition, we participate in statewide advocacy. I want to first start by thanking the Commission and the experts on today's panel for your work to address early childhood mental health. I'm just going to quickly highlight a budget request that we have been working on with several of our coalition partners to include in the state's Children and Youth Behavioral Health Initiative. So this request includes $112 million over 3 years to expand direct access to early childhood mental health programs, such as early childhood mental health consultation, home visiting, and trauma-informed care and training. These programs are designed to improve the social emotional health of young children in non-clinical settings, including childcare, homes, and communities. As parents and children return to work and school, we anticipate increased behavioral challenges, separation anxiety, and the surfacing of undetected developmental delays. And we want to make sure that the mental health of children 0 to 5 is addressed and supported as we make our way out of this pandemic. Again, I'd like to thank you all for your hard work on this issue and the robust discussion today.
Thank you very much, Ms. Ronkowski. Ashley, if you can call on the next public commenter, please.
Great. Our next public comment will come from Chris Stoner-Mertz, who, as you recall, testified to the commission on our first hearing in this series.
Thank you so much, Ashley. We at the California Alliance, which is an organization that represents over 150 nonprofit CBOs providing behavioral health to children, youth, and families, are very excited. When I testified a few weeks ago, we had not heard about the initiative, and so now having heard about these historic investments, we are thrilled to partner with Secretary Galley, Dr. Burke Harris, and the administration around this. We know that the capacity building effort is essential, and we also know, as you've heard for the last 3 meetings, there is a behavioral health crisis amongst our youth, and the support for established CBOs is critical to ensuring that we get the right services to the communities that really need them the most. We're heartened by the proposed investments in workforce and want to elevate that urgency. We've got to address these gaps now. The rates that are paid through current contracts don't support competitive salaries for behavioral health staff, leaving many current mental health positions open to address the current need, much less increasing the behavioral health staff going forward. But we want to celebrate the focus and emphasis on workforce and look forward to a deep partnership to address these mental health needs of California's children and youth. Thank you.
Thank you, Ms. Stoner-Mertz. Ashley, if you can go on to the next public commenter, please.
Great. Our next public commenter is Justin Rausa. Justin, I'm turning your ability to talk on.
Good afternoon, Mr. Chair and Commissioners. Justin Rausa on behalf of the First Five Association, which represents the First Five County Commissions in all 58 counties. First Five applauds the leadership of the Little Hoover Commission for your commitment to studying and addressing early childhood mental health needs. And indeed, the Children and Youth Behavioral Health Initiative proposes bold new action to not just grow, but re-envision behavioral health services for children. Such supports are needed to address the adversity that children and families have faced through the pandemic, especially families of color who have disproportionately experienced hardships. Additionally, First Five would emphasize what Dr. Ghaly and Surgeon General Harris have voiced so well, the need to focus on upstream investments starting as early as possible and centering equity in the heart of the work. Just as school age supports focus on partnership with K-12 schools, early childhood strategies must look at settings where young children and families are, namely in homes, community settings, and childcare. First Five, alongside our partners, have developed and deployed such strategies for years. And just to name a few examples, investing in early childhood mental health consultation to support and equip childcare providers in identifying and addressing mental health needs and behavior concerns in children, expanding home visitation to build healthy attachment between parents and their children, and offering developmental play groups and evidence-based parent education programs to build community connection and break down social isolation and support families throughout their parenthood journey to be their child's first teacher. First Five is a partner to ensure this bold and needed initiative is successful and meets its laudable goals and aptly reaches children under the age of 5. Further thank and appreciate the leadership of this commission to study this important issue. Early childhood mental health consultation will be critical to providing buffering supports and can reduce the need for costly crisis intervention later and throughout a child's life. Such approaches will support both young children and the adults in their lives today and help address the traumatic impacts of the pandemic. In response, a holistic approach is needed, and we are requesting that $112 million over 3 years from this initiative be dedicated to expand direct access to early childhood mental health programs in non-clinical settings. Such approaches will support both young children and the adults in their lives today and help address the traumatic impacts of the pandemic. As more details emerge, First Five is a partner and resource to ensure this critical initiative reaches our youngest children. Thank you for the opportunity to provide public comment today.
Thank you, Mr. Rouser. Go ahead, Ashley.
Thank you, Justin. Next, we will move on to Marika Collins. Marika, I'm turning on your ability to talk.
Ms. Collins, I believe you are muted. Ashley, is she muted at her end? There we are.
Okay, wonderful. Good afternoon, Little Hoover Commission. It's a pleasure and an honor to be before you today virtually. My name is Marika Collins. I'm the Public Policy Officer with Casa Pacifica Centers for Children and Families in Ventura and Santa Barbara counties along the Central Coast. We are a community-based organization providing a continuum of mental health services to children, youth, and young adults, including mobile crisis services specifically for children and youth, wraparound services, residential treatment, so the full gamut of services. Again, I'd like to just applaud the Little Hoover Commission for convening a series of hearings focused specifically on the impact of COVID-19 on children's mental health. Thank you. Toby can attest to the fact that I've been on this issue of focusing our attention on children's mental health issues and crisis care. And I'm so glad to see that we are finally there today. I never thought I'd experience a $4 billion commitment from our governor's office. And I must just come out and make comments on the irony of this moment. It's a historic moment. It's one to be applauded. I've been screaming up on the rooftops about the opportunities ahead of us, but yet I need to call out the irony to this commission. We've got all of this money, we've got all of this energy and attention, and yet we have a woefully inadequate workforce. And I'm speaking as a CBO working in the community. At our agency today alone, just speaking today, we have over 40 vacancies. And I'm excluding administrative positions. I'm talking about, direct care, child care workers working in our residential programs, our MSWs, our clinicians. We simply cannot compete with commercial health plans that might be offering $100K as a starting salary, or for our direct care staff, having the option of working with incredibly abused and traumatized children and some extreme behaviors, or working at In-N-Out for $17 an hour. I mean, that is what's boots on the ground perspective is today. So while we are excited with all the opportunities, I don't know who's going to be able to do the work. It's as Chris Stoner-Mertz pointed out earlier, we're really in a conundrum, but we're ready to do the work. CBOs have the flexibility, to be in the homes before school, after school, 3 in the morning. And we're committed to this work to our own local communities that we know so well. So I really hope that your commission will give a deeper dive into looking into some of the challenges that CBOs are facing, because we're there and we want to help. Thank you. Thank you for your time.
Thank you, Marika. Next, we are going to move on to Araceli Navarro. Araceli, I'm turning on your ability to talk.
Hi, great. Good afternoon. Araceli Navarro on behalf of the Children's Partnership. Thank you to the Commission and the panel for proactively addressing children's specific mental health needs, especially in response to the adversity being experienced and by children of color. As part of the coalition with First Five and CCRC, we'd like to echo the importance of investments in mental health that begin in early childhood, and that entities that support children have the resources and technical capacity necessary to partner with local health plans and community organizations long-term to fully implement support. So thank you so much for your time, and we look forward to continuing to be a partner.
Thank you, Araceli. We have no additional public comment on Zoom or email at this time.
Thank you very much, Ashley. So, Mr. Chairman, I believe we have completed our agenda for today. I will just mention very briefly that the next meeting for the benefit of commissioners is 2 weeks from today on Thursday, June the 10th, and we will be following up with commissioners with more information on that meeting. But I think we have completed our agenda for today. Mr. Chairman, my apologies to the commission for the technical snafus, but we'll get those worked out.
Yeah, well, I have my video on and I can't, let me know whether my audio is all choppy and messed up, and I'll just, delete my face again. It seems to be working better without that. Another really revealing hearing. I think it helps us to focus on the direction that we're going. It can be discouraging when you realize that a lot of the stuff that we talked about in our prior reports still remains an issue. And I think what we heard from Mr. Ewing poses tremendous challenges. And I'm glad that Senator Nielsen and Mr. Ewing are going to spend some time together because, as I said when we first started this, you can't manage what you don't measure. And as Commissioner Aroner mentioned, this thing came about as a result of an initiative, and there wasn't enough thought given to the actual sort of nuts and bolts about how this was going to work. I'm sure lots of people, and including at that point, I think it was Senator Steinberg, were really excited about the amount of money that it was going to generate. But I think what we all understand as advocates for government efficiency, it isn't just the amount of money you generate, it's how you track it. If you hold somebody accountable for results, it's ensuring that the public remains confident that the government is doing what it needs to do in order to ensure the best use of the dollars that are taken from them in the form of this tax. So, Senator, thank you for weighing in on that. And it's always a pleasure to see my fellow commissioners. The next time I see you, I will have, if everything goes the way it's supposed to, a new hip on my right side. And I suspect by the 10th, I might be tapering off on those pain meds and be able to have a coherent conversation. So for all of you, stay healthy.
Mr. Chairman?
Yes.
If I might make a little plug here, Mr. Chairman, I see behind Ethan a book that he wrote on his shelf. Now, I have that book about California Rising. If all of you have not availed yourself the opportunity to read his book, it's a good history, but it's not just a good history about what happened one time a long time ago under Governor Brown, but it sets the stage and gives insight of where we're at this very day. So I got to put a plug in for it because it's a good book and he's one of our guys.
Thank you, Senator. It's shameless self-promotion, but thank you, Senator. I appreciate it.
I'll second that. It's a great read.
And Commissioner Schramberger, you're unmuted.
Only for the opportunity to say hello or goodbye. Once you adjourn.
And Commissioner Sidley, you're unmuted.
I just want to know where Ethan, the exact name of the book so I can go out and get it. Do I buy it on Amazon? I need some data so I can then go get it. Thank you, Senator, for the pitch. I'm all in.
Yes, you can get it on Amazon. Yes, it's on Amazon. I'll send you a link, but you really don't need to get it. That's very nice of Senator Nielsen.
I guess that means,
be nice. I'm curious now.
So Jana, I guess that means we need to get to Sacramento so we can have a book signing.
Exactly. Yes, I'm there.
Folks. All right. If there's nothing else, then I'm going to adjourn the meeting. Everybody, please stay well. If you haven't been vaccinated, get vaccinated, and we'll see you in June.
All right. Thanks, everybody.
All the best to you, Pedro.